Lateral meniscus is not attached to the lateral collateral ligament. So these are the 2 points, these are the 2 facts which are extremely important for you to remember, that medial meniscus is attached to the medial collateral ligament, lateral meniscus is not attached to the lateral collateral ligament. Medial meniscus is attached to the capsule in its entire periphery, while lateral meniscus is not attached to the capsule posteriorly. Alright, for the provision of the space where the popliteal tendon is passing in between the two. As a result of which, medial meniscus is very firmly attached while the lateral meniscus is loosely attached. So if you take any structure which is very firmly adherent at both the ends and is subjected to a trauma, then this impact will result in the breakdown of that structure. But if there is a structure which is loosely attached, so some of the impact might be responsible for the movement of this structure and the resultant impact would be lesser, thereby causing less possibility of breakdown of that structure. So out of the two, medial and the lateral meniscus, medial meniscus is more firmly adherent or more firmly attached. It is more commonly injured. Medial meniscus is more commonly injured. As far as the tests for this meniscal injury, remember, test for meniscal injury, write it down. Test for meniscal injury are concerned. The first of the test is McMurray test, then Apley grinding test. Although the number of tests are many, but these are the tests which are important for you to remember, the McMurray test and the Apley grinding test. What happens in McMurray test? You make the patient lie supine, you hold the thigh in flexion, the knee is also in flexion, and you are holding the ankle. So while medially rotating it, you extend the knee joint, and while externally rotating it, you extend the knee joint. Imagine if you externally rotate it and then extend the knee joint, and if there is a click felt or the condition is too much painful for the patient, it is the medial meniscus which is injured. And if you internally rotate it and then extend the knee joint, it will be a test for the lateral meniscus. That means McMurray test is for both medial as well as lateral meniscus. Alright, but imagine if you are projected with a question that McMurray test is for medial meniscal injury, lateral meniscal injury, medial collateral ligament injury, or lateral collateral ligament injury. In that case, it will be for medial meniscal injury. Why? Because medial meniscal injury, medial meniscus is more commonly injured. So if at all you have to perform McMurray test, it will be performed for the medial meniscus. But it does not mean that McMurray is not for the lateral meniscal injury. This is something that you have to remember. Similarly, Apley grinding test is by making the patient lie prone, flexing the knee joint, and then grind it by putting it into internal and external rotation, the ankle, and the impact that you have on both internal and external rotation will be a subjective event for medial and the lateral meniscus respectively. Alright, so the name of the tests are important for you to remember. As far as the management of this thing is concerned, the treatment of medial meniscal injury is concerned. Now just try to understand the treatment of medial meniscus, because medial meniscus is more commonly injured. If there is a tear there could be a tear in so medial meniscus is divided into 3 zones, 3 peripheral zones. This is the outer, this zone is the outer 1/3, this is middle 1/3, and this one is the inner 1/3. And the difference in between the 3 is that outer zone is considered to be a red zone because it is more vascular, or it is most vascular. The middle one zone is known as red and white zone. Vascularity does not mean that it is having the vessels. It is receiving the nutritional supply by a diffusion process. Alright. So red and white zone. And it is having a mid sort of vascularity, while the inner zone is considered to be a white zone because it is avascular. This zone is avascular. Now just try to understand, if there is a tear, if there is a break in the inner 1/3, if there is a break in the inner 1/3 zone, then what it will lead to? There will be no healing, because even if you suture it, even if you repair it, there will be no healing because this zone is avascular. So for any break which is involving the inner 1/3, it has to be removed, while if there is any break which is involving the outer 2/3, it has to be repaired. So if there is a tear in the outer 2/3, it has to be performed by arthroscopic repair, while if there is a tear involving inner 1/3, then it has to be it has to be treated by partial meniscectomy. That means not by complete meniscectomy, partial meniscectomy. That means you remove the inner 1/3 circumference of the medial meniscus. So this is all about the management protocol for these medial and the lateral meniscal injuries. All right, medial meniscal injury. Next comes the collateral ligaments. Now, as far as the collateral ligaments are concerned, just try to understand. Imagine this is the distal end of the femur, and this is proximal end of the tibia, and this is proximal end of the fibula. So obviously, the ligament which is guarding the medial side will be a medial collateral ligament. So this is the medial collateral ligament, while the ligament which is guarding the lateral side will be called as lateral collateral ligament. Now, what are the two possible injuries which will result in medial and the lateral collateral ligament injury respectively? Imagine if a knee joint is subjected to a lateral force, means a force from the lateral aspect, then what it will lead to? It will lead to a bending of the knee joint onto the lateral aspect like this, and this excessive bending of the knee joint on the medial aspect, if there is a force from the lateral aspect, it will force the knee joint to move to have a apical bending on the medial aspect, as a result of which there will be a tear in the medial collateral ligament. All right, now tell me the name of the force. The force is hitting from the lateral aspect. That means it is forcing the knee joint to go into valgus. So it is a result of a valgus injury. That means medial collateral ligament is a result of a valgus injury. And the name of the test to demonstrate this medial collateral ligament injury is a valgus stress test. Because when you stress the knee joint to move into valgus, it will go into valgus, more valgus compared to the normal, because there is no medial collateral ligament which is preventing this excessive valgus from happening. On the other hand, if the knee joint is subjected to, imagine if this is the knee joint which is subjected to a force which is coming from the medial aspect, it will force the knee joint to go into or bend into the lateral apical deformity. So if there is a force which is coming from the medial aspect, it will force the knee joint to bend with the apical deformity onto the lateral side, thereby causing a tear in the lateral collateral ligament. That means a force which is bending the knee joint into varus. So lateral collateral ligament is a result of a varus injury. And the name of the test which is required to demonstrate this lateral collateral ligament injury is a varus stress test. That means when you ask a patient, when you try to force the knee joint to go into varus, then it goes more into varus compared to the normal. It is because there is no lateral collateral ligament which is preventing this excessive varus from happening. All right. So this much you need to remember about these collateral ligament injuries. Remember, the confusing point is that the impact is on the medial aspect, then the tear will be on the lateral side. Similarly, if the impact is on the lateral aspect, the impact or the tear will be there on the medial side. So this is the confusing point, but once you have understood the nature, it will become much easier for you to identify. As far as the eponymous fracture related to these injuries are concerned, is a C-gond fracture where there is a complete tear of the ACL. There will be an anterior cruciate ligament tear, complete tear, along with the tibial spine fracture, with the fracture of the tibial spine. All right, so that is C-gond fracture. And unhappy triad of O'Donoghue, as the name indicates, unhappy triad, that means there are going to be three components of this unhappy knee triad. One is the complete ACL tear, complete tear of the ACL. Second is medial meniscal injury. And the third one is medial collateral ligament injury. All right. So in a single knee, if all these three structures are injured, then it will render the knee joint highly unstable. And because of this instability, the possibility of this knee joint to rehabilitate to a normal extent is extremely less likely. So that is why it is considered to be an unhappy triad of O'Donoghue. And this is the reason why this is also very commonly asked in your questions. So hopefully you have understood everything related to this lower limb trauma section.